Mindfulness-based relapse prevention for the treatment of gambling disorder among US military veterans. Case series. This was printed in Sage Journals. Abstract. Gambling disorder, GD, occurs at a higher rates in U.S. veterans than civilians. The present case series describes the application of a manualized mindfulness treatment used with U.S. veterans seeking outpatient treatment for GD at a Department of Veterans Affairs hospital. Mindfulness-based relapse prevention, MBRP, was developed to treat substance use disorders, but its core principles can be readily applied to the treatment of behavioral addictions. However, there has been little empirical evidence demonstrating its successful application for GD, and none demonstrating its successful implementation with U.S. veterans. 3 veterans receiving treatment for gambling disorder participated in a 9-session adapted MBRP protocol. Following completion of treatment, the veterans reported less frequent engagement in their gambling behavior, fewer cravings, and less intense craving. The veterans also experienced increased self-efficacy in managing urges, less impulsivity and emotional dysregulation, and improved functioning. Preliminary results provide support for a larger treatment trial for veterans seeking treatment for gambling disorder. 1. Theoretical and research basis for treatment. Although the diagnostic clarification of behavioral addictions is relatively new, they have been discussed for decades in research, clinical literature, and in popular press. Behavioral addictions involve a compulsion to engage in rewarding non-drug related behavior without regard to incurring negative physical, mental, social, and financial consequences. Binge eating, frequent shopping, and overuse of video gaming are examples of behaviors that may lead to the development of a behavioral addiction. In the present article, we will discuss a common yet understudied behavioral addiction among U.S. veterans: gambling disorder, GD. Originally developed for the treatment of substance use disorders, SUD, this case series describes the successful adaptation and implementation of the mindfulness-based relapse prevention, MBRP, intervention for the treatment of problematic gambling in U.S. military veterans who were being treated at an outpatient specialty mental health clinic in a Department of Veterans Affairs medical center in the Northeast United States. Gambling disorder description and prevalence. GD, formerly pathological gambling, was originally defined as an impulse control disorder, but has been reclassified as a substance-related and addictive disorder in the DSM-5. GD is a psychiatric disorder characterized by recurrent and maladaptive patterns of gambling behavior that cause clinically significant impairment and distress in one's life. Common forms of gambling behavior include the use of electronic gaming devices, casino-type table and card games, lotteries, dice games, wagering, and sports betting. The severity of gambling disorder is defined as mild, meets 4 to 5 criteria out of the total 9 criteria, moderate, meets 6 to 7 criteria out of a total 9 criteria, and severe, meeting 8 to 9 criteria out of a total 9 criteria. Over the past 20 years, researchers have often described individuals as having problem gambling if they endorse 2 or 3 diagnostic criteria but do not meet the full criteria for gambling disorder. GD is associated with adolescence and young adulthood, male gender, ethnic minority status, lower socioeconomic status, lower education level, familial history of gambling, unmarried status, intimate partner violence, and risky sexual behavior. Both GD and problem gambling are highly comorbid with other psychiatric and substance use disorders. Among U.S. military veterans with gambling disorder or problem gambling, common co-occurring conditions include post-traumatic stress disorder, PTSD, and alcohol use disorder, AUD. The estimated lifetime rates of GD among U.S. adults range from 0.4% to 1.6%, and between 1% and 4% for problem gambling. For U.S. military veterans, estimates suggest that lifetime rates of GD are approximately 2%, while the lifetime rates of problem gambling are as high as 9%. These increased rates suggest a vulnerability towards developing problem gambling and GD among U.S. veterans. Despite these data, there is a dearth of research describing the prevalence of GD and effective treatments for U.S. veterans. Mindfulness and mindfulness-based relapse prevention for gambling disorder. There are varying conceptual definitions of mindfulness that often differ when describing trait or state mindfulness. Additionally, there are varying methods and approaches of mindfulness inductions and interventions that positively impact the person's functioning and well-being, both immediately and with long-term practice. Mindfulness-based interventions, MBI, have demonstrated promise in the treatment of varying physical, psychiatric, and substance use disorders. There is growing evidence that MBI may be effective in the treatment of problem gambling. There is less research exploring effectiveness of MBI among U.S. military veterans, despite evidence indicating that this population are at increased risk for developing GD in their lifetime, which often co-occurs with high rates of psychopathology, example, SUDs, PTSD, depression. Addiction treatment tailored for U.S. military veterans must therefore address the multi-morbidity often found in U.S. veterans with addiction issues. The present case series investigates whether a single addiction-focused MBI, MBRP, might serve as one approach to treat GD among U.S. military veterans, a population who have reported an interest in mindfulness-based intervention as a treatment option. MBRP has demonstrated effectiveness in supporting SUD recovery. MBRP is a treatment approach combining aspects of relapse prevention, mindfulness-based stress reduction, and mindfulness-based cognitive therapy for depression. In the context of MBRP, the act of being mindful is commonly described as paying attention to the present moment with purpose and without judgment. In the treatment of addiction, mindfulness practice intends to bring awareness to the experience of cravings non-judgmentally and without reacting to them. In contrast, cognitive behavioral approaches utilize cognitive interventions of restructuring and reframing thoughts related to cravings and urges, but cravings can be complex, stemming from more than cognitive processes. In response, MBRP was created to integrate cognitive behavioral skills training and mindfulness meditation for treating addiction. There's a growing body of research exhibiting empirical support for MBRP for substance use recovery. For instance, the results of the first randomized controlled trial evaluating the efficacy of MBRP as a treatment for SUDs revealed a reduction in days using the substances and the magnitude of cravings, as well as an increase in acceptance and awareness compared to treatment as usual. Further, Bowen, Wetkowitz, and others assessed the long-term effectiveness of MBRP in a 12-month follow-up period and found that individuals in MBRP had significantly fewer days of substance use and drinking compared to relapse prevention and treatment as usual. Meta-analysis examining mindfulness treatment for substance use noticed that mindfulness treatments were effective in decreasing substance use days, the intensity of cravings, and stress. Neurobiologically proposed areas targeted by MBRP include, but are not limited to, the amygdala, the anterior cingulate cortex, the ventral striatum, and the prefrontal cortex. These brain regions play a substantial role in developing and maintaining SUD. SUD and GD share clinical features and presentation, and there is evidence that the same brain areas play a role in both addictive behaviors. Therefore, given the two disorders' clinical and neurobiological overlap, MBRP's exercises should show similar benefits of those struggling with GD. Due to the similarities between GD and SUD, we posit that MBRP could be an effective treatment for gambling disorder among U.S. military veterans, given previous findings on MBI more broadly. Overall, the research mentioned above indicates that there are current gaps in the understanding treatment approaches for gambling disorder, and there is evidence suggesting that MBRP can reduce craving and drug use in SUD, which suggests that MBRP could have a positive treatment effect for other addictive behaviors. Therefore, we expect similar benefit for GD, and specifically, we expect to see less engagement in GD behavior engagement, decreased cravings, and less impulsivity. In addition, this case series explores whether MBRP might improve a patient's functioning more globally. No studies have assessed MRBP as a treatment for GD, and therefore we offer this case series to illustrate the utility of MBRP as a treatment for GD among a sample of 3 U.S. military veterans. Case introduction. The participants for this study were U.S. military veterans engaged in outpatient mental health care in the Behavioral Addictions Clinic at the Department of Veterans Affairs Hospital in the Northeast United States. The Behavioral Addictions Clinic is an integrated outpatient recovery-oriented clinic that began in 2016. The clinic provides a wide range of services for veterans and active duty military personnel, including evaluation, individual and group psychotherapy, medication management sessions, in addition to training and consultation services for other healthcare providers. The clinic staff consists of a licensed clinical psychologist, research psychologist, social worker, nurse practitioner, and board-certified addiction psychiatrist. The clinic also serves as a training clinic for trainees in family medicine, psychology, and social work disciplines. All trainees received weekly clinical supervision by a licensed psychologist, SWK, who supervised the MBRP group. All patients completed a standardized clinical intake where they are assessed, diagnosed, and referred for appropriate treatment offered within the clinic. Data reported in the current case series also includes diagnosis taken from the initial intake appointment. Among veterans and active duty service members treated in the clinic, almost 95% of the patients are men, ranging in age from mid-20s to mid-70s, with the average person seen being in their 50s. The behavioral addiction issues referred for treatment to the Behavioral Addictions Clinic are GD or problem gambling, compulsive sexual behavior disorder, binge eating, and problems with shopping, video gaming, and overuse of the internet. GD is one of the behaviors most frequently addressed within the clinic. At the time of referral, veterans are typically in significant distress from these behavioral addictions and have suffered significant negative consequences in their lives, including impaired interpersonal relationships, homelessness, and unemployment. 3. Presenting complaints. 3 veterans in this case series identified problems in their lives that resulted from gambling disorder and expressed that the experience of stigma and shame made it difficult to initially seek treatment in the behavioral addictions clinic. When engaged in the MBRP group treatment in the clinic, veterans were provided a set of assessment measures at the initial and final group meetings. Within the assessment measures, veterans were asked questions regarding their engagement in the problematic behavior, intensity of urges, capacity to handle urges, intensity of craving, frequency of craving, length of craving, and frequency of craving. P, short form. Lastly, the veterans reported less emotional dysregulation after treatment as measured by the DERS-SF. Cognitive, physical, and social functioning. All 3 veterans reported increases in cognitive and physical functioning as measured by the CPFQ, where lower scores indicate better functioning. Mr. A and Mr. B reported no change in social life and familiar and home responsibilities as measured by questions from the SDS. Mr. C, however, reported improvement in these areas. Treatment implications. The results of this case series suggest MBRP could serve as a viable trans-diagnostic treatment option for addressing gambling disorder. 3 veterans were enrolled and completed the entire protocol, marking MBRP's feasibility and acceptability as an intervention for veterans with GD. It is particularly noteworthy that the veterans completed the MBRP treatment protocol, despite their reported shame, guilt, and concern about others' judgment prior to beginning the treatment. We believe that knowing that they would not be required to explicitly discuss their gambling behaviors and the ramifications of those behaviors to the group allowed them to feel comfortable enough to participate and commit to attending all the sessions. While other clinical settings may incorporate the use of shared experience and self-disclosure as clinical tools, the Behavioral Addictions Clinic's group guidelines about self-disclosure demonstrated benefits by both levels of engagement and completion rates. This approach highlights the importance of developing stigma reduction strategies to decrease shame and guilt among individuals seeking mental health care services as a necessary step in achieving positive treatment outcomes and addressing potential treatment barriers. Despite these proximal measures of feasibility and acceptability, additional attention needs to be given in future studies 2. The subjective experience of the MBRP group members regarding the specific aspects of the program that they found most supportive and beneficial in their recovery from gambling disorder. Throughout the course of MBRP treatment, 2 of the 3 veterans reported less gambling. All 3 veterans reported reduced frequency in cravings to gamble and greater self-efficacy in managing their cravings over time. It's important to note that although the frequency of engaging in gambling was measured, the intensity or duration of the gambling was not assessed, a limitation of the current case study which may be of consequence. For example, it may be possible that Mr. C did not reduce his gambling frequency, example, number of times he gambled, but he may have reduced the intensity or duration of his gambling. Example, reduced from 5 to 3 hours of gambling. Unfortunately, such data was not collected, but it's recommended that future studies should include both gambling frequency and intensity. Self-reported mindfulness, impulsivity, and emotional dysregulation improved from pre to post-treatment. Specifically, the veterans reported greater mindfulness, less impulsivity, and less emotion dysregulation. The veterans also reported overall improved functioning. All 3 veterans reported apparent substantive and consistent improvement in cognitive and physical functioning. For 1 veteran, there was reported greater social and familial functioning after treatment. The experienced improvement in overall functioning may serve to further support the veteran's recovery by better managing and interacting with others in their daily lives. The veterans within this case series study reported varying active psychiatric comorbidities, including PTSD, schizophrenia, and bipolar disorder. Substance use problems are also common among U.S. veterans with GD, as shown in this case series, with all 3 veterans having a history of polysubstance use, and 1 veteran in this case series reported active tobacco use. Also, we found that 1 of 3 veterans reported suicidal ideation within the past year. Suicidality is a concerning pattern among veterans with GD and remains an important clinical consideration in treating this population. This reinforces the importance of screening for suicidality among veterans reporting problems managing their gambling. Veterans are an increased risk for developing gambling disorder, and it continues to be a chronic yet understudied problem among veterans. Despite gambling disorders' comorbidity with other psychiatric and substance use disorders among those seeking treatments, and its association with suicide and homelessness. Likewise, there is little empirical evidence demonstrating treatment efficacy for gambling disorder among this population, which is known to have more complex psychiatric histories compared to their civilian counterparts. Mindfulness-based treatments are well regarded by veterans, and the clinical and neurobiological similarities between SUD and gambling disorder suggests that MBRP could serve as a viable approach for gambling disorder treatment. This case series serves as a first step in demonstrating MBRP as a promising treatment option for veterans struggling with gambling disorder. Recommendations to clinicians and students. As research continues to better elucidate gambling disorder among this high-risk population, it is important to pair the research with the development and testing of psychosocial interventions to treat gambling disorder. This case series suggests that MBRP is an acceptable and potentially efficacious intervention for the treatment of gambling disorder among veterans. Future research is needed to test this intervention in a large, well-powered, randomized controlled trial for veterans seeking treatment for gambling disorder. Acknowledgements. The findings and interpretations of the data reported in this article are the sole responsibilities of the authors and do not necessarily represent the views of the Veterans Health Administration or the University of Nevada, Las Vegas. Declaration of conflicting interests. The authors declared no potential conflicts of interest with respect to the research, authorship, and/or publication of this article. The authors received no financial support for the research, authorship, and/or publication of this article.